Thanks very much for that introduction. I'm Shreya. I'm one of the Maxillofacial Registrars at the dental hospital, and I also work at the Austin. So today I wanted to talk about post-operative pain management for dental patients, but also for dental alveolar and maxillofacial patients as well. But more importantly than just post-operative management, I want to talk about peri-operative management of pain. So what is pain? There's a group called the IASP who have defined pain, and they've defined, I'm sure you guys have heard of this already, but it's an unpleasant sensory or emotional experience, and it's associated with either real tissue damage, so that's in our surgical setting, but also potential tissue damage. And why do we care about pain management so much? It's absolutely about patient comfort, and that's extremely important, but it's about more than that. If our patients are in pain, especially in the setting of maxillofacial surgery, they're not going to be able to eat properly. And as part of that, they can get dehydrated, their nutritional status can suffer. Also, if they're in pain, they're not going to be able to cough. And this is important for maxillofacial patients, but also for other surgical specialties like patients who've had abdominal surgery. And if you can't cough properly, then you can aspirate, and your risk of getting lung infections is much higher. That also goes in setting off being able to mobilise. If our patients are in pain, they're miserable, they're in bed, they're not going to get out of bed. That's when things like DVT, especially in the setting of inflammation and surgery, can happen, and then that can go into PE as well. And also for patients that are in chronic pain or are in pain for a long time, then they can decondition. They're not moving around, and their muscle mass and things like that are going to get worse as well. But also from a bigger picture, if people are in pain, they're in hospital, they're not going to go home, and that's got actually quite a significant amount of cost to the health sector to it as well. And also we know for a fact that if you have poorly managed perioperative pain, then your risk of developing chronic pain and chronic pain issues is higher. So what affects a patient's pain experience? Why do some people have a bimaxillary osteotomy with no issues, go home after 24 hours, and then other people hate it and they stay in bed for a week? So part of it is their previous experiences, including their previous pain tolerance. Also their tolerance to medications, and specifically opioids, because that's something that you can build quite a significant tolerance to. And their pre-existing pain issues. If they're already sensitised, if they've already got a pain disorder, then their risk of having issues in the surgical setting is much higher. And that's something that we really need to be aware of. Also what they're expecting. If you tell someone that this is going to be the worst operation ever, then they're going to expect a little bit of pain. But on the other side of that, if you don't explain anything and then, cut their jaw and cut into their jaw, then it's going to be a surprise. So it depends. You need to manage their expectations of the pain as well. And then also, of course, what you're actually doing to them. And we're going to talk about that in detail as well. So what can we do to manage their pain? There's physical things. So a lot of our patients upstairs get ice packs post-operatively, and they're told about ice packs and heat packs at home. But also pharmacologically, we can do things that are quite important, like giving good local anaesthetic. That's why our patients, when they're asleep, they'll still get blocks, and they'll get blocks with long-acting anaesthetic. And also we can look at, not specifically for dental alveolar surgery, but we look at the role of regional anaesthesia. And then also systemic analgesia, and that can either be oral, IM or IV. And then like we were saying before on the last slide, it's really important to manage the patient expectations. And part of that is distraction. So you tell the patients are in pain, but you give them goals to look forward to. You say this is what you can eat, and we talk about jaw opening exercise, especially for our TMJ surgery patients. And we sort of try and stay goal orientated and try and distract them a little bit safely from their pain. So I'm going to talk quickly about preemptive analgesia. There was a study which came out a little while ago, and it's been replicated a number of times in the past, which shows that it's really important to give preemptive analgesia and post-surgical analgesia. So they found in their study that this is the group of patients who didn't, who didn't receive adequate surgical anaesthesia or post-surgical analgesia. And then they said, okay, for the next group of patients, we won't give them any local anaesthetic during the procedure. We'll just give them post-surgical analgesia. And that it made things better, but it really didn't do a lot. Then for the third group, they said, we'll give them local anaesthetic during their procedure, but then nothing afterwards. And they didn't have pain during the operation, which is the green line, but they did have pain afterwards, and their risk of hypersensitivity post-operative was there. And then lastly, this is the group that we try and replicate all the time, which is when they have local anaesthesia. So while the operation is happening, they don't have nociceptive input. But even after the local anaesthetic wears off, they get post-surgical analgesia, and their risk of hypersensitivity is the lowest. Does that make sense? Yeah. So regional anaesthesia in our setting relates to blocks, and specifically you know how local anaesthetics work. And you know that it's important in terms of where you put the local anaesthesia, but also what exactly you put in. So you can do an infiltration around areas which are going to absorb that to the nerve, but then also there's blocks for specific areas like the inferior alveolar nerve and the infraorbital nerve. In other types of surgery, such as in pelvic surgery, so gynae and things like that, you can use spinal anaesthesia or epidural anaesthesia. And just out of interest, there is another thing called a Beer's block, which is when you can use it for an arm or a leg, and you basically put a tourniquet on, and then you run local anaesthetic through the circulation in that arm without it letting it get to the rest of the body. Sort of. And then, like we said before, there's types of local anaesthetic, which is lignocaine, things like the lignocaine which are faster acting, and then things like bupivacaine which are a little bit slower. And I guess the important thing to remember about bupivacaine is that it's slower to stop working, but it takes also a little bit longer to start working. And in that case, if we, and we're notorious for this, but if you put your local anaesthetic in intraoperatively, it hasn't actually started working yet, and it doesn't actually start working, your Marcaine, for the first 10 to 15 minutes. And that becomes important in terms of designing what you're going to be doing, and also watching the patient to see if they're having a response to what you're doing, to see if you haven't yet got local anaesthesia effect. So the thing that we're all most commonly going to do for our patients, apart from the local anaesthetic side of things, is to give them oral analgesia. And the things to think about is their medical history, their existing medications, what they're already on, and that includes what you've already given them. So for example, patients that have had a long-acting non-steroidal during their operation, you wouldn't start their Nurofen straight after. And also what they're going to be like. If your patient's going to be vomiting post-operatively, then there's no point giving them oral analgesics. There we go. Other things to think about is if they're allergic to it. And I know a lot of our patients, especially at the dental hospital, will say that they're allergic to certain medications that they've had before. And it's important to know if it's an actual allergy, which means that you shouldn't be giving it, or if it's an intolerance. So things like opioids, they will cause nausea and vomiting as a side effect. They'll cause hallucinations, they'll slow down your GI mobility, and they can cause itchiness as well. That'll happen to most people at a high enough dose. So it's important to differentiate that, because if someone's had quite significant levels of morphine, for example, when they had a knee replacement and had nausea and vomiting, then it doesn't mean that they can't have Panadol Forte or they can't have Tramadol. But it's important to work that out from if they've had a true allergy to it. The other ways that we can give patients medications, and this is especially important if they can't take things orally, so if they've got nausea and vomiting, or for example, what we did this morning was a bimaxillary osteotomy, which they're not going to be able to swallow tablets because of the pain of swallowing, of where we've been operating. Then other things to think about is things like subcutaneous, and especially morphine is quite easy to give subcutaneously. Obviously you would do that in a hospital setting. Also IM, there's lots of medications including non-steroidals that patients can have as an IM dose, and that's much longer lasting. And then of course there's IV, and specifically to patients that are staying in hospital after an operation, then you can have things like a PCA, which is patient-controlled analgesia. And that's basically when they've got access to a button, and every time they press the button it gives them a small volume of a drug, and it can either be fentanyl or morphine or something like that, and then it locks them out of the system so that there's a safety barrier so that they can't overpress their button. And all of those parameters can be controlled by this machine. And the other way that we can give analgesia is intrathecal, which is sort of like an epidural. Now, you guys will also have heard of the pain ladder, and the WHO defined this some time ago, basically just to make sense of why we give patients analgesia and in what combination we give it. So basically, if you've got a patient who you're taking some wisdom teeth out of, you don't give them tramadol and that's it. You start from the bottom and you give them paracetamol. If they need to, then you would add on to that. And in the case of wisdom teeth, you would give them non-steroidals. And then on top of that, you can give them things like codeine or tramadol. In bigger surgical settings, which is a bit more than wisdom teeth, you can add on the stronger opioids if you need to, but you still keep that baseline medication of your paracetamol and NSAIDs, because that'll bring down your opioid use. So what are your options? We spoke a little bit about paracetamol, which we all use, and non-steroidals, which we all use. Then there's opioids, and we know that there's a huge range of opioids that we can choose from, and opioid-like drugs. But then there's a couple of others that I want to talk about quickly, which is Gabapentin, NMDA Antagonist, and alpha-2 antagonists. And that's only really just to know about them and what to do if your patients are getting to the top of that barrier. So they've already had their Panadol, they've already had their codeine, they've already had their non-steroidals. And then just to think of what else is out there that's beyond that on the ladder. So the first drug that we're going to talk about is Panadol, and it's one that we've all used before. It works centrally, so it's quite a good drug, and the only sort of situations that you would consider not using it is in patients with liver problems. We would normally give it either IV or oral, and it's quite a safe drug in most healthy patients. So the next one is non-steroidals, and non-steroidals are specifically useful in the setting of post-operative pain because they're anti-inflammatory, right? So they work exactly, and they target the way that those patients are going to be experiencing pain. But there's a couple of things to think about with non-steroidals. The first one is your anaesthetist might have already given some longer acting non-steroidals in the operation. So paracoxib or Dinostat is quite a common drug that's given during the operation for your surgical or your sort of intraoperative pain, but it can last in the body for up to 24 hours, so 8 to 24 hours. And because of that, you don't want to start them on their post-operative Nurofen or whatever you choose until that's worn off. The other thing is that it can be very useful for fever as well. So if you've had patients with a slightly for example, an incision and drainage of an abscess, and they were getting septic and things like that, it can have other benefits. But the receptor that non-steroidals work on is also important for protecting the gastric mucosa and also platelets. So the downside of using non-steroidals is that if you use them for a long time, then that can cause stomach issues, and specifically gastritis or gastric ulcers. but also some of them can cause platelet dysfunction as well. But that's usually in the setting of longer term and higher dose non-steroidals. So these are a couple of common ones that are used. Ibuprofen most of us would have used, and diclofenac as well was quite a common one. And then an IV option, like we said before, which is an intraoperative option, is paracoxib. So the patients to not use this for are patients who've had gastric mucosal problems, so your gastric ulcers or gastritis, but that's not 100% contraindication. That's just something to think about, and we can talk about that in more detail later. The other thing is if you've got patients with significant bleeding disorders, then it's something to be cautious about. The other thing is if you've got asthmatics, and specifically asthmatics, some of them may have non-steroidals as a trigger. And then, of course, if they've got renal dysfunction because it's metabolized renally, so there can be an overdose for them, and also if they're a higher risk cardiac patient for some of the non-steroidals that we use, because they can also have that the COX-2 effect. Do you guys have any questions so far? No? So the next one is opioids, and we've all used opioids probably in the setting of codeine, which, as you know, is metabolized to morphine, but there's also lots and lots and lots of different types of opioid-like drugs. They're highly variable in the way they act and in their dosing, and they also, like we were saying before, have quite a lot of adverse effects. They act centrally on the brainstem and on the CNS, and some of the things that they can do is cause that respiratory depression. So for those patients that are immediately post-op and they're drowsy anyway, we wouldn't be pushing too many more opioids into them. But also if they're sedated for any other reasons. It can also cause nausea and vomiting. It can cause itchiness. It slows the gastric mobility down, so it can cause constipation and ileus, which is basically when the small bowel stops moving temporarily. And that can cause, again, nausea and vomiting, and it can cause bloating and a lot of pain and make people quite sick, actually. The other side of this slowing down effect that morphine has is it can cause urinary retention, and that's one thing that's often missed in patients, especially elderly patients, is post-operatively they've had wisdom teeth out and all of a sudden they've got this tummy pain and they can't understand why, especially older patients who may have dementia and may not be able to communicate as well. So urinary retention is one thing that in the hospital setting can often be missed and can often be quite painful for the patient. And then of course with longer term opioid use, there's the issue of tolerance and addiction. So I won't go into this in too much detail, but opioids are metabolized both through the liver and through the kidney. And if someone's got kidney failure, then that you have to be really cautious about how much morphine or opioids you give them. The reasons why you would hold off on opioids or be extremely careful in opioids, like we were saying, is if they've got kidney failure, if there's history of addiction, and even if they're on things like Suboxone, buprenorphine and things like that, then they're all things that we need to think about when we're prescribing these drugs. And also if they're sedated. And if any of these things do turn up in sort of the general surgery side of things, you can get an issue when patients have had too much morphine, or sometimes they've had the normal dose of morphine but we didn't realise they've got kidney problems, and then that normal dose becomes an overdose for them. And then all of a sudden these patients can get drowsy, they can have respiratory depression, and it can become quite an issue, and it's one of those things that you can often get a MET call about. And then what you can do for that is, as part of your normal MET call response, you go through your ABCD, but you can also give them naloxone And what the naloxone will do is it'll reverse the opioid. The downside of that reversal is that it can cause an increase in pain, and these patients can get agitated, and also one of the side effects of naloxone is it can cause hypersalivation. So that, together with the risk of the respiratory depression, can be an issue as well. So the next group of drugs, just quickly, is gabapentin and pregabalin, and these also work on the CNS, and that's starting to get more into the sort of atypical spectrum of things, but they are still very useful post-operative pain medications, and they were initially used as anti-epileptics. They're quite useful, like I'm sure Dr. Heafy would have been talking about, in neuropathic pain. But if you use them in conjunction with opioids, they can reduce your opioid use by quite a bit, of up to half, really. So for some patients who've had some bigger surgery, especially skull-base surgery and things like that, sometimes they can get things like gabapentin as well. But again, it started off at a low dose and it's incrementally worked up higher. And if you're getting into the use of, or if you're thinking about using gabapentin and pregabalin in a post-operative surgical setting, then that's usually things that we would get the pain team in for. We wouldn't do that by ourselves. So the next group is NMDA antagonists, and I'm sure we've all heard of ketamine. And that causes an atypical analgesia. It causes like a dissociative analgesia. So you sort of, it's more, you can still feel the pain, apparently, but it doesn't bother you as much. The good thing about ketamine, and why ketamine's quite useful in some situations, it doesn't cause your cardiovascular depression. It doesn't cause those issues of sedation and respiratory depression and all that kind of thing. The downside is that it's a drug that's out on the streets a little bit, and you can have some issues with patients asking for it specifically and things like that, and it needs to be in a controlled environment. The other thing is, if you've got patients with schizophrenia, it may make that worse initially. And it can also cause some interesting side effects like hallucinations and paranoid delusions and things like that. So nitrous oxide is also technically an NMDA inhibitor, and it also works in the same spectrum, but not quite as strong as ketamine. And then the last group that we're going to talk about is alpha-2 agonists, which is basically clonidine, and that's another drug which is used in post-operative settings. So it's just one to be aware of as an option, and it also works centrally and is quite useful for post-operative pain. So there's a lot of options that you can choose from. There's more out there than your Panadol, Nurofen and codeine, but that's not the main part of it. The main part of it is to manage your patient's expectations, do all those other things like giving a good block, talking to your patients so that they understand what to expect, and plan on what you're doing. So when we talk about post-operative pain, then it's something which involves quite a lot of people. It involves very definitely the patient. It also involves the surgeon, but also together with the anaesthetist. So often for patients that are a little bit tricky, we'll talk out a team plan beforehand. So for example, we had a patient last week who needed an open sinus lift and an implant, and she had fibromyalgia and some chronic pain issues. And we spoke to the patient in detail. We spoke to her GP. We spoke to the anaesthetist who was going to be doing her anaesthetic on the day. And before we went in there, we knew exactly what she was going to be doing for during the operation, but also for the next week after the operation. In the hospital setting, you've also got the benefit of having an acute pain team, and they will be able to help to talk to you about options like PCA and options like using ketamine infusions and clonidine and things like that. But also you've got all your allied health and physio and things like that, and they're fantastic in terms of pain management and getting the patient to mobilise, but in a safe way and working through the pain and past the pain. And also your nursing staff. Nursing staff are amazing at motivating patients to get out of their bed, but also very important in making sure that they're actually getting their analgesia regularly and getting it appropriately. So I guess the idea is that we're going to be personalising the analgesia to the patient, and that analgesia is more than just drugs, and also that it's always multimodal. So it's physical, it's through drugs, and that's either systemic, regional or local, and it's also through patient management methods.